Now, good morning, Mr. Stephen.
Good morning, my lord. The first witness this morning is Robert Pollock.
Good morning, Mr. Pollock.
Good morning, Lord.
Now, when you're ready, Mr. Stephen.
Thank you, my lord. For the record, the inquiry reference number for the witness statement here is SCI WT 0354 5 zeros and a 1. Good morning. Can I ask you to confirm your full name, please?
Yeah, my name is Robert John Pollock.
And your age and contact details are already known to the inquiry, so I won't ask you for those. You've helpfully provided a written statement already, which the inquiry has seen. Are you content for that statement and the oral evidence that you give today to form your evidence to the inquiry?
Yes.
Good. And are you happy for that evidence to be recorded and published?
Absolutely, yes.
Thank you. And everything you've said in that statement will be taken into account by the inquiry, even if we don't touch on every single aspect of that today.
Thank you.
Okay. And just a final reminder before I start asking you some more questions, that a restriction order is in place, so please do not name any specific individuals if you keep it at a higher level, if that's all right.
No problem. Thank you.
Thank you. What's your current role?
Sorry?
What's your current role?
My current role, I'm a clinical advisor paramedic based in Cardonald, Glasgow. It's the control room. I acquired that position as a consequence of my own health problems as a front-line paramedic. When COVID first evolved, I was risk assessed and deemed not suitable now to front-line patient facing. So I had to find an alternative role through time now to sustain my future within the ambulance service.
And how long have you held that role for?
This is my 24th year, I believe.
In that role?
No, this role is basically from 2021. So this is my 24th year within the Scottish Ambulance Service.
And so before that, before you undertook that role and prior to the pandemic, am I right in thinking that you were a frontline paramedic?
Yes, I was based in Glasgow South Station, Govan Hill, Glasgow.
And am I correct in saying that I think near the start of the pandemic, you say in your statement that you had to leave duties as a paramedic and then undertook other roles instead?
Yes, I did. I've done a variety of roles on behalf of the Scottish Ambulance Service to keep myself employed, if you like, now active and doing something productive. I've done flu vaccines, for example, now for lots of members of staff. I also carried out stores deliveries of personal protection equipment. I delivered that within the kind of local areas now to different stations, fire stations, etc., to ensure that the levels, this is further on after the commencement of COVID, but it's just to ensure that the levels were topped up on a frequent basis.
And I think you just confirmed already that you've worked for the Scottish Ambulance Service for, what, 23, 24 years?
It's my 24th year I'm on just now, yeah.
And how many people does the Scottish Ambulance Service employ, do you know?
The approximately 5,500, I think, now is a reasonable. Now, fluctuates obviously, but I think that's a bit fair now.
Across Scotland?
Yes, yes. Obviously, a variety of roles now. The patient transport, the paramedics, technicians. You've also got admin staff now, office staff, control room staff, and others, logistics, etc.
And I think you say in your statement there's something 230, I think it is, vehicle stations or something.
Yeah,
across Scotland?
Again, I think that's reasonable now. Thereabouts.
I wanted to ask you about your role with the GMB trade union, if I may. You're also branch secretary for the GMB trade union for the Scottish Ambulance Service branch, is that right?
That's correct.
And how long have you carried out that role for?
I've done that role for about 6 years in total, but prior to that I was a branch president, so I've done a high-level role for about 12 years now.
Okay. And how many members are there in that particular branch?
Approximately 2,000.
And what in high-level terms does the branch do for its members?
Well, we're involved in negotiations, working in partnership with the Scottish Ambulance Service management. We have a kind of government scheme whereby we're working in partnership is critical to the ongoing now discussion, negotiation, problem solving. We do negotiations for salaries, look after members' interests, deal with disciplinaries, grievances, etc. The whole range of workplace issues that may arise now.
And we'll come on to the subject of PPE in more detail, but suffice to say for now, I understand from your statement that when the pandemic hit, you were given the task on behalf of GMB to monitor PPE levels and quality for the Scottish Ambulance Service. Is that right?
That's correct. I was a nominated person to attend the meetings with the Scottish Ambulance Service senior management on a frequent basis. Yeah.
Thank you. So I'll ask then, for you to cast your mind back to the start of that pandemic. And at paragraph 8 of your statement, I think you say that the Scottish Ambulance Service started to hold regular meetings, I think daily meetings, I think you say, regarding COVID. Were those in person or virtual meetings?
Yeah, they were virtual, yeah.
Okay.
They were virtual. They were set up initially daily. It changed to probably the second day, or if something unforeseen popped up, it was quickly arranged again for, and it could have been the next day again, if that makes sense. So a bit of fluctuation, but initially it was each and every day, Monday to Friday.
And you attended those meetings. What was your role at those meetings?
My role was predominantly, from my responsibility was to look after my members' interests, and the members were advised that I was available now for any of their concerns. So a bit of hotline, for want of a better word, where they'd contact myself looking for advice, help, or pass on their concerns regarding different issues that the pandemic created for them.
Thank you. And what were the frequent or main concerns that members were raising with you to raise at those meetings?
There was a variety. Initially, I don't think panic would be the wrong word, but certainly a lot of high-level concerns regarding the availability of the personal protection equipment and the standard of it. Now, what was available wasn't what they expected now to go front-face patient services. They wanted a much better level than was currently available at that time.
And how did you keep abreast of what was happening in each of those? We talked about how many vehicle stations there were, how many staff there are. How were you getting that information in order to feed it back?
Obviously, I was getting phone calls from, we cover the whole of the Scottish Ambulance Service as a trade union. We're getting phone calls from different locations, north, south, east and west, remote and rural. And that gave me a kind of quick picture of now there's something badly wrong regarding distribution of personal protective equipment and availability of it. So when I was made aware of that, I set up different people in different areas to keep me regular contact. They'd update me basically daily to see what the levels of stock in their location were, and if they were based in Inverness, for example, they'd also pick up the local stations surrounding the north of Scotland now and give me as best an update as they could do now regarding the availability of a variety of personal protection equipment.
Thank you. Paragraph 10 of your statement, I think you say that the Scottish Ambulance Service listened to your input. I wondered if you might give the inquiry an example or examples of where your feedback meant that they changed what they were doing.
Well, if for example, I got a phone call from Inverness, I'll use that as an example again. We've got 10 FFP3 masks, we've got 100 surgical masks, etc., etc. I would update the Scottish Ambulance Service. That's not enough there. We've got now 30 staff per day and approximately now 10 different masks depending on your patient involvement. So you'd require now maybe 400 for that particular station on a daily basis. So I'd update them to say, listen, this is not sufficient, and we have to ensure we get supplies here now rapidly, as quick as possible, and I'd give them a rundown of the information I had, what was lacking badly within a given area as much as possible.
And I think it's paragraph 12 of your statement that you say that at these meetings they would often over-promise and under-deliver, they, I think, being the Scottish Ambulance Service. Yeah. What do you mean by that when you say that in the statement?
Well, during these meetings, they would give us an update on stock availability in a central location, not overall locations, and what their expectancy was for delivery of more appropriate or even more levels of existing PPE, and took that in good faith, obviously. So if they, for example, told me we're getting 5,000 Solway now FFP3 masks in Monday morning, I would relay that to try and minimise the concerns of our members, now the people out there front facing. Bear with us now, they're doing their best to get the equipment that you're demanding, and hopefully by Monday it'll be here, and more often than not that didn't materialise.
And what would you say then was the impact upon your members of, as you describe, as being over-promised and under-delivered on this material?
I think the key one was that myself, and I'm quite well known within my trade union, and they're relying upon myself now for facts now and support. and if I gave them facts and supports in good faith and it didn't materialise, it put myself in a position now under the spotlight now. But I don't think, as I said in my statement, I don't think it was a deliberate attempt to mislead. I just think, as I said, they were over-promising and maybe let down by other third parties in the cycle of delivery. But the information was given in good faith, and if it didn't happen, it was probably more damning than not giving the information, if that makes sense.
And was that a source of concern to your members when this?
Oh, absolutely, because they were working under pressure with the perception. Initially was based upon perception, because the virus, the consequences of it was a bit unknown to everyone, apart from what you could see on the national television. But other countries, Italy, for example, been a good example. Initial onset of COVID here. Some of the scenes on the national news were horrific, and I think that set the tone for the fear and anxieties. And this is coming here next, if that makes sense.
Yeah, thank you. Now, you'll be aware this inquiry is obviously looking at the Scottish Government's response,
yes,
strategic response to the pandemic. Yeah. So I'm interested to know your awareness or knowledge of whether the concerns that you were raising at these meetings about PPE and anything else that you raised, do you know if that was fed back to the Scottish Government, whether that was through the ambulance service itself or through GMB? Was that relayed, do you think?
So my personal involvement was with the senior level of management within the ambulance service. However, we do know by dialogue now they were then communicating with the Scottish Government now for obvious reasons, and the tea time broadcast from the First Minister at the time would kind of reflect the conversations we had of that day, and also that was then brought to the table for the meeting for the next day, or the next day the meeting took place. So it was quite obvious there was a dialogue now happening to with who and when, I can't tell you, but I just know by the conversations and the sharing of information that must have been taking place.
So to summarise then, you didn't directly necessarily deal with the Scottish Government, but as far as you're concerned, those concerns were being relayed down the track by senior management, I think.
Yes, absolutely.
Okay, thank you. You briefly mentioned this earlier, but I'd like to ask you about this GMB hotline. This is at paragraph 13, you mentioned this. When would this hotline have been set up, and what was the purpose of it?
It was set up basically in March of 2020, and the purpose was to give members a direct access now to help, support and some facts. They had a variety of concerns, not just about their own personal protection with the available PPE or the lack of it. They also had fears about them taking the virus home and going exposed to people with COVID, now knowingly going to a job with people with COVID. And they had fears about, for example, they might have looked after elderly grandparents or parents. Now they had caring responsibilities at home, so they'd do their job, and then they were worried about what they're taking back to their home, now their parents or their children at that time, the unknowing now part of COVID, and it didn't materialise now there and then, so you could have it unknowingly, and if you did then spread that to now parents or anyone you were responsible for, the fear factor was that you can give them something that maybe have now severe consequences to their health.
And who was manning this hotline?
Myself.
Right. And what was the volume of calls that you were receiving?
Well, initially, as you can imagine, it was I called it the hotline for a reason. It was non-stop. Hundreds of now calls and calls waiting, now messages left. I had to filter my way through them now hour by hour when I got a space in the day, attending meetings and go back to missed calls, etc., and trying to update people as frequently as possible, but be as factual as possible on any information they were trying to get. They were lots of trying to get some confidence from what I could tell them, but I had the responsibility to make sure I only told them what was factually correct. I couldn't give them respite from their fears and anxieties because I didn't have the information that would equate to that at that time.
And you mentioned, I think, people looking after elderly relatives or living with them. Are there any other particular groups that you would highlight that were using this hotline? Yeah,
so, again, the ambulance service do have some procedures in place now, policies, procedures for different illnesses and ailments. Now, workforces have got now different problems. COVID being mainly respiratory type now virus. Anybody who had asthmatic problems, now COPD, now other high blood pressures. There was a whole range of staff who weren't quite in the bracket of protection, but thought they should be. And it took a bit of time for the ambulance service and the Healthcare Scotland, the WHO, they were all given advice on who should be shielded, if that makes sense. I think shielded was a word that was used quite commonly then, protected now from frontline facing. Some were given alternative duties, like myself, now doing something functional, but not the frontline role. Other ones were just now given respite from employment at that time, depending on what their personal health circumstances were. The fear and anxieties was that a lot of the people were not included initially, and they thought they should have been, and eventually there were some concessions given, and we expanded now the amount of people were encompassed within protected levels.
When you say not included, do you mean within the shielding cohort? They thought they should be, but they hadn't been initially. Is that what you mean?
Yeah, well, they stipulated protection. They had certain criteria. They didn't meet the criteria in the eyes of the Scottish Ambulance Service, so it took a bit of pressure from myself, a wee bit of negotiation, discussion, and evolving evidence to say, yes, now there is more people. We have to expand this area to make sure that everybody that needed protection was protected. And that could be just the fact that they were full carers for very, very, very vulnerable people, not themselves personally with an issue. So there's a whole range now. The physical people that need now, the asthmatics or COPD and others, pregnant women within the Scottish Ambulance, to be absolutely fair, are normally removed from frontline duties as soon as they're confirmed. Now, the pregnancy is ongoing, if you like, the first positive test, but they've still done some operational duties, and they'll still be facing paramedics or technicians or patient transport service staff come back into the area where they worked. So we had to get a system that was safe. Most pregnant women at that time preferred to work up, now do something till nearer the date of the expected child delivery, and that then gave them more time with the child and maternity leave. So they were still in premises, and on that basis we had to make sure that they were protected, even despite the fact they weren't front facing, that they were removed from potential cross-contamination of other staff within the buildings.
It's obviously a difficult time. Was there a tension between those that were obviously having to shield and therefore away from frontline duties, and the impact that might have had on the rest of those that were working as paramedics?
Obviously they expressed their personal concern. I mean, I can use myself as a good example. When I was removed from the frontline responsibilities after a risk assessment by my team leader at the time in Glasgow. Initially, he told me I was fine, I'd passed now the risk assessment. A few moments later, I came into the mess room to advise me that part of the criteria was my age. And at that time, I was 60. And once he incorporated my age into the risk assessment, I failed miserably. I felt a bit guilty about that I'd been removed from now responding to the patient as my colleagues were. But it was out with my hands, but it still didn't take away my personal feeling of it. Guilt, I think that's the best way to describe it. I felt a wee bit, I'm letting them down.
Yeah, thank you. And do you think there was any resentment from others that were having to still plough on, as it were, and be paramedics with that happening?
I wasn't aware of any specific resentment, but given the pressures and the anxieties, now there was people being excused now from the traumas that they had to go and face. So I can only think now, logically, that yes, some people say, no, they've got away with it kind of thing, then we've got to go and do it, if I want a better word. But nobody came to me personally and had any negative comments to me, but I still feel it was definitely there now, and I certainly felt now a wee bit strange that I had been excused from it and others had to go and do the job.
Thank you. I'd like to ask you now about PPE. You raised quite a lot of questions in your statement. I'd like to ask you about those. I think, yeah, you say there's a wide range of concerns and questions, I think, that came to you in your capacity as of the branch. I'd like to ask you first, in paragraph 14, you talk about all-in-one suits and their availability. So I want to ask you about their supply. What was the issue there, and what was the information you were receiving from your members about that?
Okay, so we did, I mean, prior to COVID, with different now contagious patients, etc., and you put on, basically, for a common word, you put on protective equipment. Now, it's an all-one, it's almost like a boiler suit, but it's material that keeps now invaded bacteria away from your own personal uniform and your personal self. They were there, but very limited supply. We didn't have much usage of them. They sat in stores, and very, very infrequently you had to access them. However, when COVID presented itself, and given the unknown aspects of it initially, people were obviously looking to get these coverall suits to give themselves as much protection as possible. And the availability was very, very poor, and size-wise, were XXX, 4XLs now for a 5-foot male or female, now was absolutely ridiculous now, not fit for purpose. And it took a long time to get now more appropriate sizes and quantity of these particular now suits that would offer some protection.
When you say a long time, I mean, could you?
Months. It took months, and every day went by when people couldn't access them. Then obviously they get more anxious. There was news reports from other now health boards, London for example. They were showing now taking patients to and from hospital, arriving there with now all the suits and the best protection. It was visible to others to see, and they were asking the question, why are we not now getting the same availability, now the same level of protection? There was no protection known that would absolutely exonerate you from now contamination from COVID, but myself and the people actually carried out the job were expecting the best available now to be there for their use, and it wasn't.
And would you say, therefore, given what we're saying about all-in-one suits and them being of a massive size that didn't necessarily suit everyone else, did that, do you think, place colleagues at a greater risk if they weren't able to utilise those?
Oh yeah. No, the equipment is designed to minimise now contamination, not your body, your uniform, etc. And if you're doing now 4, 5, 6 patients, sometimes more per day, you've got 3 uniforms in total. They have to be laundered, so your coverall suit would protect your uniform now from bacteria. So your next patient wouldn't be cross-contaminated. And I think the key is that although people were suspect COVID, there was no confirmation at the time when the ambulance service would pick them up. You could highly suspect it given their presentation now, high temperature, coughing, headaches, now a whole range of things, presentation-wise. But you certainly couldn't now say they're definitely COVID positive. That came later. Your fear was, if I pick up Mrs. Jones, my first call, I then go to Mrs. Brown, the second call. Now, what are you doing to now each and every patient? And you had to minimise that risk by the appropriate PPE. You removed it safely, and then you attended the next job, and you took the necessary steps regarding what PPE you had to reapply for the next patient, depending on the call it was and what was reported on the 999 line for help, basically.
Thank you. In paragraph 16 of your statement, you mention a possible difference between the PPE that was supplied or available to those in, well, I think specifically London, but England paramedics, and those in Scotland. Why do you think that? Why do you think that was, and how did that come to pass that you noticed this?
I just think they're maybe more prepared in some parts of the country, but the GMB are a national trade union. We are GMB Scotland. However, we do have now national meetings with others, and we're having now really conversations into a central base about what was available nationally. I didn't get involved in that specifically, but we were getting reports now of availability and lack of availability in some other parts of England, for example. Yorkshire had issues, but the London one seemed to be quite frequently on the newsreels, and you could quite easily see them arriving, now the paramedics, with the full monty, if I want a better word, your PPE, your visors, now the FFP3 masks, gloves, boot covers, lots of things that wasn't available to us over the first several weeks of this virus.
And I think you say in your statement that you kind of pled for that same level of PPE to be provided. Were those pleas heard or not?
They were obviously recognised as concerns, but again, I think the management team were doing their level best to obtain, but it was due to availability. I think they'd missed the boat, for want of a better word. I don't think they were prepared for a virus. And one of the concerns for me was that, I can't remember the name, we had an exercise, but I think fine for the hit paper, I think it was 2017, we had an exercise, almost a dummy run, if you like, for a potential pandemic. And that highlighted now a lot of failings, that we didn't have enough equipment, didn't have enough people. What would happen if a pandemic did arrive on these shores? And I don't think, personally, that they picked up the lessons that brought to the table. I think if they had done, I think they'd be in a much more ready state when it did arrive. If we'd learned from the rehearsal, if you like, if I want a better word. It was an exercise based upon the facts available from other countries having now other issues. Now, bird flu way back now, lots of things can cause serious public health concerns. And there was a lot of lessons learned from that, and I think it demonstrated that we weren't quite ready for it if it did arrive. And despite that exercise taking place and the passage of time, we certainly, in my opinion, we were nowhere near ready for now a COVID-type virus.
Just for completeness, was that lack or apparent lack of parity between, say, paramedics in London and what you were seeing in Scotland, was that fed back to the Scottish Government, to your knowledge?
Yeah, again, also I highlighted grave concerns now at the next available meeting, but when people were seeing that for their own eyes, now that, again, our hotline would make people, well, how come we've not got now? Obvious questions. Now, we're demanding the same level of protection, we're covering the same virus, with the same potential recipe for disaster for themselves and their families now. So they wanted the best available equipment. And if you see someone else now, a couple of 100 miles away, having it, and you've not got it, it just created more pressures, more anxieties, and a bit of discontentment between now the employees and employer. Now they felt let down by their employer.
I want to ask you now about out-of-date masks. I think this is something in paragraph 18 that you talk about.
Sorry, I've come off a flight and my ears are not...
No, it's fine. Yes, no, it's fine. I'm happy to repeat it. I was just saying I wanted to move on, I suppose, to the quality, if you like, of PPE now, having talked a little about supply and quantity. It's the quality now, and it's about out-of-date masks I wanted to ask. It's something you talk about in paragraph 18 of your statement. What were your members telling you about that as an issue? So the base equipment that was available in ambulance service stations now for routine jobs was surgical masks, and the paper masks that were freely available to the public. And they were there, and obviously they came in pre-packed. I think there was 5,000 per box of these particular masks. They came in a brown box similar colour to the table with the identification of the contents, how many contents, and an expiry date now for when you should dispose of them once the expiry date's elapsed. There was a lack of even these basic masks in the early stages, and eventually we got some stocks in, but instead of the plain cardboard box, there was a A4 size label placed on the outside of the box, and it had new details about the contents. Somebody, Ayrshire, I know who it was, but I won't mention the name, but somebody in Ayrshire peeled away that label to expose the expiry date, and these were well out of date. The masks that had been brought in as new, and that obviously raised a red flag to myself, a bit strange. So I brought it up at the very next meeting. That was causing grave concerns. The people's impression and perception was that their employer was covering up now the reality of the contents of these boxes, hoping now that nobody would recognise it. In reality, when I questioned the Scottish Ambulance Service management on this, they said that they had tested a small sample, tested one or two out of the box of 5,000, and they were deemed fit to be utilised. When the staff were using them, because there's nothing else, they've got a kind of almost a talcum powder type effect if they're disintegrating slightly now by time, and they're putting them on and get this powder release, and some of the
elasticated straps that held them on the back of their ears were popping. They were dangerous, for want of a better word now. They weren't sufficient. But not everyone was like that, but it only takes one.
Yep.
If you're doing your job, and if it fails its purpose, it puts you in a strange state of fear and alarm. As a consequence, you had to rely on what you had to protect yourself and others. And if you didn't have the confidence in it, which they didn't, it caused extreme fears and alarms. My thoughts, and I think I mentioned that in my statement, if they had done what they said, and I haven't got any evidence to say they never now done a sample testing, if they had done that and advised myself and others, we could relay that information to people to give them some comfort now prior to it, but just bringing them into a stock situation with the label covered, if you like, created a sense of insecurity and fear that they thought their employer was pulling the wool now over their eyes and just, listen, this is what we've got, just get on with it kind of thing. But the staff obviously identified them now different from the other arrivals, therefore they done their nosy and they had a look at the actual expiry date under this label. That lack of communication, lack of knowledge hadn't been given in advance. The service said that they were sense-checked the equipment, it was fine and fit for use. That lack of information prior to them arriving caused a lot of anxieties and discontentment between employees and employer.
And to be clear, you talked about the employer. I'm just, in terms of who you think was, I'm not asking you to name individuals, but who do you think it was that was covering up these expiry or dates for the PPE, just so I'm clear in my own mind? As to
I don't know is the answer, but I do know they had a central store of equipment, so they had like a location where all the available equipment they could muster up came into, and then it was distributed from there to different locations throughout Scotland. And that was one of the issues, because the mass volume of work for the Scottish Ambulance Service just by population is inner cities, your Glasgow, your Edinburghs, Dundees, Invernesses, etc. But we've got the same people now carrying out one person going to a patient in Outer Hebrides is still under the same potential risk. So initially the availability in some of the outlying areas was very, very poor now, extremely poor.
Would one rationale for the supply of these masks, you're saying a sample test was done, is, for what I'm trying to paraphrase, I suppose, would it be making the best use of what was available? I think you've talked about shortages. Do you think that would be one explanation as to why that might have been done? Yeah,
I think they had nothing else to offer, and I think they're probably working on something's better than nothing. But that works in most fields, but not in a health professional field. When you're people, your paramedic, your technician, anyone, your patient transport service, you're trying to do the job on a continuous basis, looking after the patients to the best of their ability in a professional fashion, but they've still got their own personal fears now for their own safety, as well as the safety of patients. Now, the masks not only protect them from you, it protects you from them, if that makes sense. And if you didn't have the confidence in the equipment, then it gave you a very anxious day at work.
Thank you.
Very stressful day.
In paragraph 19, I think you say there was also a serious issue with a type of mask, the 1863 FFP3 mask. Can you describe what that issue was, please?
Again, we had different people within our trade union were given the task of face fitting. That involved, kind of, for want of a better word, a small chamber where a non-toxic gas was inserted into the chamber, a control substance. And if me, for example, had the available mask, the FFP3, at that time the 1863, place it on, you do a wee kind of jogging exercise under instruction. The tester would have a monitor and it would pick up any invading toxins. In other words, the mask wasn't sealing to your particular contour of your face, your body. And if that was the case, it came up as a fail and you had to be tried for a different mask. Now, you had to try one that actually was adequate for your personal purposes. The 1863 had an absolute horrendous fail rate, and the people who were testing, being colleagues of people frontline facing, obviously information gets shared quite quickly. Now these masks are not now not sufficient for the job they're intended. We then had again, I won't mention any names, but we had a senior manager saying that they were to be stopped to be used with immediate effect, and the next day, or not maybe even the same day, later on that day, anyone had been previously tested with them and passed should continue to use them. So it was a kind of stop-start. Yeah, they're not good enough for some people, but good enough for others. Again, that caused more fear, more anxieties. And one of the more concerning issues, the testing of the face fitting, which is classified as face fitting, it's a certified position. So you get trained by a specialist to allow you to carry out this testing. And what the Scottish Amber Service does, they got the people who had been passed this certification to speak to others, to bring them into the loop. So it wasn't trainers training, if you like. It was just getting down domino effect almost, and that produced some bad habits. There was some bad instruction. People were told to pull the elastics now a lot tighter than what they should, against the manufacturer's instruction tells you not to do that. They were also changing the nasal bridge, like a small metal section. They were squeezing it right in, and basically it was almost a very, very tight facing mask. And it was quite evident they were trying to get more of a successful pass rate, but the consequences of not following the manufacturer's instruction would be that if it's too tight and it's causing sweat, rashes, your tendency is now as a human just to scratch your face and now go under the mask, and that you've then exposed yourself, if that makes sense, because you don't know what you've been touching. Gloves on, you're then going under your mask, you're trying to relieve the irritation. That kind of thing happened, and some of the masks were breaking during the actual physical use of them. Now dealing with a resuscitation patient, that pops off, you're then now exposed for that moment in time, dealing with a very ill patient, and obviously that then created massive fears for the individual concerned.
You say at paragraph 43 of your statement about members being frightened of carrying out CPR. We talked about PPE disintegrating. I think you also talk about this being interrupted the ability of members to concentrate and amplify their stress levels. So I suppose my question to you is, overall, given what we've talked about in terms of availability and the quality of the PPE that was available, do you think that had an impact on the ability of Scottish Ambulance Service staff to do their jobs?
Absolutely. I think the Ambulance Service were working on guidance to say that the surgical masks were sufficient except for intubated patients now. And if you've got a very ill patient, a cardiac arrest patient, now they'd be intubated, now tubed down into the lungs to get a better air in, to protect their airway now from vomit, etc., etc. So it's a standard, the gold standard for protection at that time was to intubate your patient, and the WHO detailed that as a airborne risk, because you're pressing air in, air's coming out, you're ventilating the patient, and you've got obviously an oxygen cylinder operating, and the sheer practice of intubation and bagging masks, oxygenating the patient, created a more of an airborne risk. And the Scottish Ambulance at that time, that's the only time you really have to wear the full FFP3 protection mask. That didn't go down well with the staff, but if they were wearing one of the lesser branded ones and it didn't do the job, as in if it failed or it removed itself because the elastic string snapping, then they're exposed now at high risk. That was classified as a high risk. Now, ongoing CPR with chest compressions, airway management was a high risk, because obviously there is air being transferred, and any virus that patient may have had, and you're suspecting the patient's now succumbing to a combination of their existing medical conditions with COVID, or sometimes just COVID in itself for people who had no previous knowledge of any issues. There's a full range of different criteria. It's unknown, unspecified. Some were gravely ill, got COVID, and their chances of survival were minimised as a consequence. Others were normally fit and healthy, but succumbed to the virus for reasons unknown to me at that time.
Thank you. Before we move on then, I just wanted to ask if you had any specific lessons learned you'd like to highlight to the inquiry, specifically on PPE.
Well, I think one of the key ones was that the Alpha Solway mask was the mask that the staff had the most confidence in, and I think confidence is a big part of relieving personal stress and anxieties. So they had this product which they were comfortable. I mean, it looked good. Now it's looking like an old-fashioned cartoon. It looked good. It felt good. It fitted the face fitting for that particular mask was in the high 90%, for example, opposed to the 1863, which was now the low 20%. So it had a feel-good and a knowing good effect. People were comfortable with that. I believe they shut that factory just at the start of COVID. So I think they were based in Dumfries at the time, and that was due to lack of finance from the Scottish Government, which is quite well detailed in the press. And one of the MPs made a statement about it at that time. It's ridiculous that we're going to have to rely upon other countries now out with the UK for supply of PPE. We should have a facility, in my opinion, that we can upscale very quickly. We have a supply availability for the first 2 weeks, for example, but we should be able to produce by ourselves to ensure that we've got enough medical PPE equipment to minimise the risks to the people out there dealing with the next pandemic, if and when it comes.
Thank you. I wanted to move on then briefly just to ask about long COVID. At paragraph 46 of your statement, you say this is something that you yourself suffer from. Can I just ask you, when were you diagnosed with having long COVID?
Well, I'll give you a bit of background first of all, and it maybe help. So, as a consequence of not being able to do the front-face patient role, I done, as I said earlier, I done lots of flu vaccinations. I done store deliveries. I was keeping myself proactive and contributing in some way now to the efforts of the needs of the service and the needs of the patients. Longer term, I had to try and find myself in an equivalent position that sustained my own employment. And there was a vacancy popped up for a clinical advisor paramedic, which is basically utilising your skills as a paramedic, but on a telephone triage basis. So rather than go out to see the patients directly, I would call them on the telephone. I had access to a live feed if I wanted it, now visualise them, or just audio, vocal to vocal. And it was my job to ascertain what their status was regarding availability of ambulances on a priority basis based upon their current condition. But I went for that particular post to maintain my own employment, and part and parcel of that was to go to Norseman House in Edinburgh, one of the major head offices for the Scottish Ambulance Service, for C3 training, C3 being the computerised system that allows you to develop a triage system via the telephone. I arrived there on the Thursday, and the tutor came into the room. They did have social distancing in place at that time, I might add, in that building. They had a one-way system for the canteen for accessing tea and coffees, etc. Unknown to me, they had a major outbreak the weeks prior, significant outbreak within that building. And when the tutor came into the room, we had social distancing. So a room that would normally hold 8 people had 4. As you walked in the door there, the tutor's desk was to this side, myself facing this way, and another couple spaced out at the back of the room. But he came in and said he had quite a severe headache. Bear with him, he was going to take some paracetamol and come back, which he did do. And we were there for the Thursday, Friday, and by the weekend, myself and all others in that room were gravely ill, including the partner of the tutor. Ventilators for 2 of them. I was intensive care, had 9 IV antibiotics each day for 7 days in a row, 63 in total. And my consultant says that the fact that I hadn't smoked was probably the reason why I'm still here today.
And you talk in your statement about the impact that long COVID has had on your own health and, of course, on your working life as well.
Yeah.
In paragraph 52 of your statement, you say that members have witnessed their colleagues who have contracted long COVID being treated badly, and they will not forget that. So I suppose my question to you before I move on is, what are you saying that you think something could or should have been done differently in terms of the handling of long COVID?
Yeah, I think that I mentioned that, and again, I just want to reiterate that my personal experience is not. I'm not mentioning that for me. I want to get that absolutely clear. My personal experience, I've been a gross enlarged liver and a widespread pneumonia as a consequence of it. It's not for me personally. There's other people impacted in the same way. My rationale for mentioning that, using myself as an example, is to ensure that if we have an outbreak in a building, now any building, then there has to be more consideration to who you're inviting into that building now at that particular time. And that's the reason why I just want to make that clear for your last question. That it's not for me personally. It's everyone under the same restrictions as me should have been more protected and therefore minimise any risks to their health as a consequence. And I just want to make that absolutely clear, because it's not about me, it's about us, if that makes sense.
Thank you. And the final thing I wanted to ask you about then is do not resuscitate. That's a section of your statement that's dedicated to that, paragraphs 26 to 30. And you talk about a practice, I think it is, of toe tagging. I just want, and a letter that you as paramedics or the Scottish Ambulance Service received. Could you just elaborate a little bit on?
I actually tried to find the correspondence via, I couldn't find it, to be absolutely blunt. However, my recollection is absolutely clear. There was discussions around age grouping for toe tagging. In other words, people over a certain age now, your normal attempts at resuscitation would be minimised. And I think, just to make it clear, there is no age limit in Scotland for now resuscitation of a patient. Any patient that's needing resuscitated will be an attempt at resuscitation. A minimum of 20 minutes advanced life support is recommended before somebody would say life extinct or beyond help, as the case may be. And a paramedic can certify now the patient's beyond help. They can't certify death, but they can certify, in other words, we can stop resuscitation after a certain period of time. And as a consequence of the discussions, they were mentioned 70 and over initially. There was reference to the potential, and I'm firing for memory here, but I'm pretty confident the forecast, worst case scenario, was 3,600 deaths per day, kind of thing, if it invaded the population to a gross extent. People were looking at the Italian version, the high level of stress and anxiety, the doctors crying in waiting rooms, people in the corridors now. That was the fears that people were visualising. It didn't materialise in the same fashion here. Definitely never hit that type of level, but the fear was there, because that's what we were seeing now on televisions. And your main point was?
Well, no, I was just asking about the background to it, but I suppose, I mean, in paragraph 28, you talk about rumours that the government, and I assume you mean the Scottish government, but I'd be grateful if you could clarify, had a plan to reduce that age group you were talking about to the over 50s.
Yeah.
Did that ever amount to more than rumour? I mean, as you'll appreciate, we're obviously looking at the Scottish government's strategic response.
It was absolutely in discussion, and they had a kind of 70, 60, 50 escalating process, and that was relayed now. It was relayed in a kind of strange fashion. The HCPC, the Healthcare Professional Council, did send out correspondence to registrants. Now that only includes paramedics from the Scottish Ambulance. It doesn't include your technicians or your patient transport services. They are not registered bodies. It's your paramedics and up as far as clinical skills are required. And it basically said that they realise there's tough times ahead, and if you had to work out your normal levels of professional expectations, they would support you greatly. And the way it was worded, I think the only interpretation that people could make would be now relative to this situation regarding not giving now your full attempt at resuscitation certain patients, depending on the age or condition in some places. That didn't sit well. Every professional paramedic has got an inbuilt now. We try to save every single life, every single occasion, to the best of our ability until such times it's futile. And that type of potential expectation caused a lot of fear and alarm. And for example, if you personally were a paramedic and your mother was 75 or 80-year-old now, what's going to happen now if they take unwell? So again, there's a fear factor there. There's also the professional indifference. People didn't feel comfortable now that they couldn't do everything humanly possible for every patient. To what extent that materialised, it's a bit unknown, but it was certainly high in discussions. And that, at that time, if the COVID invasion, the pandemic had increased alarmingly more than it did do, that was certainly on the agenda now for action. And that in itself did cause some grave concerns for almost every paramedic, to my knowledge.
So you said on the agenda, but was there any formal, informal messaging from the Scottish Government itself on this issue?
Unknown to me, but I do know, obviously, that the information from the hierarchy of the Scottish Ambulance Service was coming from somewhere. Now, it's not, they weren't decision making on their own. They were relaying information given and kind of putting people on alert to what may be around the corner, if that makes sense. Pre-preparing people now for that eventuality. I've no knowledge of what figures, if now, what people suffered this detriment now, as in lack of attempt. I've no actual figures, but I do know it was discussed now, and it was a possibility. And the fact it was a possibility caused a lot of stresses and pressures.
Thank you. I don't have any further questions for you, Mr. Pollock, so I'm grateful for your evidence both in writing and orally today. Was there anything else that, before we conclude, that you'd like to add in terms of lessons learned, or otherwise anything you think we haven't covered?
I just think in general, I mean, the reason why I've kind of volunteered to come here today is just to highlight now the initial concerns. I think the country now, not just the government, everyone has to be more aware of these pandemics. They have to be more prepared to minimise the risk to your front services, your healthcare workers, now your people working in care homes, nursing homes. We have to protect the people who are doing their best to ensure the best outcome for all patients. And I don't think that was the case on this occasion, and I hope it is the case going forward. I think we should be much more prepared. I was on holiday in Portugal over the last 2 weeks, and I got involved in a conversation with one of my colleagues who does care in the community type. And it's a good example of poor treatment. I think it has to change. These particular people need a car to do their job efficiently and effectively. And part of the criteria for having that car, you had to cover 3,000 miles per year. During COVID, 2020, 2021, 22, they didn't manage to achieve this because the COVID, the restrictions placed upon them, and these vehicles were removed. They had to remove them full stop because they didn't fulfil the criteria. And then they left people with now having to find several £1,000s to get a personal replacement vehicle literally within weeks. Totally now outrageous in my opinion. As a person, I mean, as a trade union spokesperson, and people with long COVID who different degrees of long COVID. You get people who can survive quite well, have long COVID, but myself, I've got a wee bit of memory issues. My sleeping pattern's shocking now, terrible. I can go to sleep in minutes, wake up 2 hours later, feel as if I've slept for a week now, and stop-start. Other people have got very restrictive physical issues as a consequence of long COVID, mental issues as well as physical. And initially we had protection. If these people with COVID weren't classified as a typical sickness absence. So the ambulance service have got a staging process, and you get stage 1, stage 2, stage 3 for attendance management. You avoided that process if it was COVID related, and that gave these people a bit of protection. What's happened over the last several months, that protection has been removed. So anyone who exposed themselves to high risk looking after the patients of this country and suffered COVID as a consequence, I think, for want of a better word, the governments are looking at it. Yeah, you might have got it at the local shop, you might have got it elsewhere, rather than taking a bit of responsibility for the people. The percentage is that you're going out to face people constantly with COVID. opposed to the one or two out in the community. Long COVID for them now, technically, going down to the next few months, if they've got continued absence problems, they could be basically out of a job quite quickly. Now, with no salary, no compensation, no way of feeding their family, paying their bills, etc., etc. And for want of a better word, I think they've been dumped by now the current status within the government, stroke Scottish Ambulance Service. But these rules and regulations come from out with the Scottish Ambulance Service. And I think it's unfair that people who gave their all for the patients to better their health and to look after the country have now been exposed to now financial detriment and possibly now losing their homes and very disruptive families as a consequence. I don't think it's fair. I think that's something that should be looked at.
Thank you. Thank you very much.
Yes, thank you, Mr. Pollock. That's all. 11:45, please. Thank you.
Thank you, my lord.
Good to go. Thank you very much.
Now, good morning, Mr. Edward.
Good morning, my Lord. My Lord, with your permission, if I can lead the evidence of Mr. O'Connell.
Of course, good morning, Mr. O'Connell.
Good morning, my lord.
Mr. O'Connell, can you give the tribunal, the inquiry, your full name?
Yes, it's James Jeremiah O'Connell.
Now, Mr. O'Connell, you have provided a statement, and you have a copy of that in front of you, because I'll ask you some questions about it.
Yep.
And you are happy for that statement to be published?
Yes.
Yes. And you're also happy for your evidence to be recorded?
Yes.
Yes. The reference of your witness statement is SCI WTO 277, 5 zeros and a 1. Yeah. All right, Mr. O'Connell, can you give the inquiry your details about your role within the Unite Union?
Of course, I am a regional officer for Unite the Union, and I am the lead officer for health within Scotland, so I cover the whole of the NHS in Scotland on behalf of Unite and lead on the national discussions and talks, etc.
So you have a national perspective on,
Yes.
on the NHS. Yes. And if we look at paragraph 4 of your statement,
Yep.
you say that in terms of health and social care within Unite, we've approximately 20,000 members across the UK. I mean, do you know how many members you have in Scotland offhand?
It's approximately 150,000 across the whole of Scotland for Unite.
And a large number will be in the NHS and the social care sector?
Yes.
Yes. And you mentioned the split of your membership is across all age groups and ethnicity, but is predominantly female.
Yes, across health and social care.
Yes, approximately 2/3 to 1/3.
Yes.
Yes. Now, you also say that you are responsible for health sector committees within Unite, bringing together all health boards within Scotland. Can you say something about these health sector committees and what they do?
Of course. As a lay member union, our union is decided, and our positions, etc., are decided by our lay membership. The committees for health cover, there are a number of other sectors within Unite, as you would expect, but within health, that brings together all representatives across all boards in Scotland, and those committees come together quarterly, as I say, within those are the regulated ones, but we can meet as and when required to formally discuss Unite Scotland's position within health on specific matters such as health, and we're currently, as you would expect, just to give context, going through some of the reduction in the working week, etc., within the NHS, and our committee will come together to articulate what Unite's position is in relation to how we advocate for our members on behalf, and it's the lay member structures of our union that determine that.
Yes, thank you. Now, at the beginning of paragraph 7 of your witness statement, which is on screen,
Yep.
you mention that your title is the Health and Social Care, well, the title is Health and Social Care, but I think you mean by that the health and social care sectors.
Yes.
And the membership of the union it comprises people working in both sectors.
Yes.
Yes. Now, just for the purposes of clarification, my Lord, can you just briefly explain what you mean by the healthcare sector and what you mean by the social care sector?
Of course. I think that health is predominantly at NHS. I think it's fair to say that. I think the constructs of the health and social care sector in relation to how the contractual terms of within Scotland are made up is why it becomes the health and social care sector. Social care, particularly, when I refer to social care, I'm thinking about particularly community youth, not-for-profit, third sector organisations, charitable organisations, and elements of local authorities who provide home care, who provide care at home, care within care homes, personal assistants, support workers, covering children, young and adult services that for individuals who require supported throughout their life. It could be people living and doing within people's housing settings across the piece. But that's what I refer to, or what I would suggest is through social care.
So, for example, an elderly person living at home who has a carer coming to visit twice a day to prompt them to take their pills or to help them make a meal and so forth, that would be classified as social care.
Yes. Social care provision through different contractual arrangements. Yes.
But there could also be healthcare provision in people's homes too.
Of course, yes.
And that could be provided by the NHS.
Yes.
Yes. So the union covers both sectors.
Yes.
Yes, and has members in both sectors. Yes. Now, following the structure of your statement, I will want to ask you particular questions in relation to both the impacts on what we're calling the health sector, so mainly the NHS, and also what we're calling the social care sector, where it's not just that, of course, but for example, where care is being provided in people's homes. Yes.
Yes.
Now, I'm also going to take matters chronologically, as your statement does, and so in paragraph 10, between paragraph 10 and 12, you have something to say about the preparedness for the lockdown. So this is February, March 2020, when COVID was about to hit the UK. Now in paragraph 10, you suggest that the first formal dealings that you had as a union official in relation to COVID was around early March 2020.
Yes.
Yes. And you mention a meeting, you think, in the first week of March, when you got a phone call from the Deputy Director of the Health Workforce within the Scottish Government. That was Dr. Stephen Lee Ross. Do you want to say something more about that meeting?
Yeah, I think
or that phone call, rather. Sorry.
I think first and foremost, I think to acknowledge that from the Deputy Director of Health Workforce perspective, he phoned myself and other colleagues within other trade unions themselves. The purpose of that phone call initially was to provide an overview that, because we could see what was happening across Europe, this phone call was to give an update to say the UK 4 nations are coming together to discuss a plan or a readiness in terms of what's going to happen across Scotland. As a trade union partner within the agreement through the NHS and the relationships with the civil servants within Scottish Government, it was a phone call to provide us with that update, but then to set out the parameters that there is going to be. This workforce leadership group is going to be set up initially to discuss what has came out of the 4-country conversation, so that you understand what impact that's going to be for your members. And I'm sure we may come on to it later on, but that organically grew to be something so much more than that very quickly. It was an information gathering phone call, giving us information to relay to our members and the impact, but as that progressed very quickly, the whole parameters of that group changed.
But it took time to do that. I mean, you say
Yes.
Towards the end of paragraph 10 that there was no sense of urgency at first.
No, there wasn't. I think we were all seeing, and I think I can fairly articulate that we were all seeing what was happening across Europe and China and Europe. But there was we're going to have these discussions, but it's not here yet. It doesn't really impact us. It's not something that was the feeling that I got from it. That it was, we're having this discussion. We're just trying to get ourselves organised, but we then see that we weren't organised. We weren't ready for what happened. I don't know how that was constructed, how that came about, but the feeling that I got initially was that we are discussing the potential and just trying to get ourselves kind of in a place. But as I've reflected within my statement and hopefully today, that changed very dramatically, very quickly.
Now, if I can move on then to particular impacts on your members and focus first on the health sector.
Yep.
You deal with this in paragraph 13 onwards of your statement. And what you highlight, as many others have done, is the lack of PPE. And you go on to discuss particular problems with PPE once it was available. And if I can put it this way, there are problems of hierarchies in that who is entitled to PPE and problems of effectiveness in relation to different types of PPE with particular issues around face masks.
Yep.
If I can deal first with the availability problems, what do you remember about that?
From a health perspective initially, it became very clear that there wasn't enough PPE circulating within the system to reach the demand. The risk assessments that the individuals could partake in themselves to identify which mask, for example, they would prefer, were not readily available. We also had issues where, and I talk about the kind of hierarchy bit, where initially there's, and I think I say it in my evidence, that, for example, porters, etc., who transport patients across hospitals, were told that they do not need masks because they are pushing the patient away from them. So they were then explained that they don't need masks and to carry that function out. However, if that individual was in a ward, then the employees within that ward would have been subjected to the PPE requirements to ensure the safety for themselves and the patient. But as they then started to be transferred through the hospitals, the porters were told that they did not require a mask to protect themselves in relation to that.
So if we could just explore that briefly. I mean, it's in paragraph 14 that you specifically mention this example.
Yep.
And you say there that as an example, so this is an example of hierarchies. So those at the lower levels of the hierarchy, like hospital porters, were told that they didn't need to wear a mask when transporting patients because they were behind the patients when they were pushing them. Now, I mean, at one level that's anecdotal, but I mean, can you perhaps explain who told them that and whether that was a pattern or one isolated example?
I think that who and I say that anecdotally, it was our elected representative that it actually happened to, and took place across different sectors or different areas of the hospital. I think that it was initially it was a potential belief of local managers, which then comes down to the communication of the guidance that was being provided. I think that in a lot of circumstances, local managers who were required to implement guidance were left in potentially a vulnerable position due to some of the communication of that evidence, which then created unnecessary conflict. I think that as we started to progress, particularly within the NHS, it was easier to address those situations very quickly. Because of the contacts that we have, but if you then transfer those particular situations into a social care setting, because of the under-representation of trade unions across the sector, the workforce within social care were placed in a more vulnerable situation because it was not easily accessible to address the situations that were being reported to us because we didn't have the direct contact with the individuals. When we raised these concerns, and moving this forward, it was addressed within the health sector. It was addressed very quickly, and managers were then appropriately advised about the guidance, about what needed to happen, and then there was appropriate PPE was then provided.
Yeah.
But it became the requirement of the individual to stand up and say, I'm not doing that until
Yes.
such times that you provide me with the appropriate PPE, and that was unnecessary in my view.
Yes. Well, we've slipped a little bit there into social care. I want to keep that separate for the moment because I want to come to it. If we can continue just to focus on the healthcare sector for the moment, the issue of hierarchies and effectiveness is also mentioned in effect in paragraph 16 of your statement, when you discuss the particular impact on members of not being able to access PPE in the first place.
Yes.
And what sorts of impacts were those?
As I say in section 16 of my statement, that our members had to, and I think that this is fair to say across the whole sector, I think that health workers sacrificed a whole lot, and so did social care workers, and so did all key workers, etc. But focusing on health workers, they sacrificed a whole lot of their own personal life, their own circumstances, to ensure that patients were supported, that the system continued to run. Tragically, people lost their lives, and our members and our representatives were advocating for those members who tragically couldn't do it for themselves any longer because they weren't there. One of the first tragedies within healthcare was very close to our representatives within a hospital setting, and the workforce were absolutely devastated. I think that people have all seen photographs of health workers breaking down in tears. I think it's important to reflect that that's real, that happened, yes. And it continued to happen throughout. It wasn't an isolated incident. But our members and our reps were obviously grieving for one of their colleagues. The reality that was hitting them at that point of that could have been me, was then hitting home. But because of the pressures that were under the health sector at that time, it then became, I'm really sorry, but we need you to get back to your job. And so there wasn't that time to grieve, that time to process. And the difficulty that we have, and it is anecdotal evidence, is because of how all of this stuff was reported throughout the health and social care sector. But there was a load of questions to say from our members and from our reps to say, well, actually, if we had appropriate PPE, if we had FFP3 masks, because of the amount of time spent within that hospital setting, it was clear to those individuals that the only place you could catch this tragic disease was in that setting.
Yes. So it's fair to say, with everything else going on, with dealing with the unknown, with people falling ill, with shortages of staff, with uncertainty about how one contracted COVID, the problems with PPE and not being able to access it aggravated the
absolutely,
difficulty.
Yeah, exacerbated the situation, and that was not required.
Now, if we can turn to the social care sector now, the particular impacts of these issues of PPE problems in the social care sector, you deal with this in paragraph 17 onwards of your statement.
Yep.
And I mean, again, in paragraph 17, you begin with hierarchies, the hierarchy or difference between the healthcare and the social care setting, in that what you say in paragraph 17 is for those working in a social care setting, so that's like people going to care for elderly people in their homes, for example. At the beginning, at the least, PPE was not automatically provided, and staff were asked to reuse single-use masks or not use them at all. I mean, is that because of availability problems?
Yes.
Yes. And again, where were these orders or instructions be coming from?
They were coming from the line management of those individuals who were obviously then seeking advice and guidance from their appropriate management teams, because particularly within the social care sector, there is obviously a chain of command. There is that organisational chart, but being asked to reuse single-use masks, the clue's in the title, they're single-use. That should never be the case. That should never be happening. When you talk about, and I referenced that when we talk about community nurses, district physios, they're employed by NHS, so it was clear that they would go into a house setting, unknowing what they were walking into. When they came out, they would take their PPE off, put it in a bag, and then dispose of it. Within social care settings, within other kind of charitable organisations, community youth, not-for-profit, third sector, that was not the case. People were wearing masks, the same masks, or for the whole day. Whereas there should have been reusing that when there was masks available. They shouldn't be reusing it. They should have been taking that off and to ensure that there was continued protection there. But that was all down to the availability of PPE and probably the cost constraints that were being placed on organisations due to the way that the social care sector is set up in terms of the government procurement processes, and whether or not that's part of the contractual conditions or not.
Because social care is largely a local authority responsibility, isn't it?
It comes through, local authorities are the registered providers as such, they're the commissioning bodies, but we that is then filtered down through into a load of charitable organisations who do great work and providing support to people they support and vulnerable individuals throughout our country, but it's all done through that contracting mechanisms through health social care partnerships and IGIBs.
So, of course, one feature of the social care setting then, in comparison to the healthcare setting, is that there are many more actors, many more operators.
Yes.
Yes.
Red tape.
Now, in paragraph 18, you do say there was some evidence, you yourself call it anecdotal evidence of PPE getting locked away in cupboards and being rationed. And would you say the reason for that is because of concerns about shortages?
Yes.
Now, you do say, to be fair, in paragraph 19 that the system did improve. Are you saying that it improved because of increasing availability, or people getting used to using it, or
I think that it improved because of availability, and because there were organisations who were repurposing themselves to provide and PPE. There was, if you take the dental hospital for example, within Greater Glasgow and Clyde, they then went into production of visor masks, etc. There was universities that were making PPE, single-use visors, etc. to try and provide support. So as the pandemic grew on and grew forward, we ended up in a situation where we were getting PPE. I think it is important to say that there is a difference between the PPE that was provided initially to where we ended up to. Where we ended up, there was what was called tiger masks, tiger goggles. They were just procured because of we needed masks, but those masks were not fit for purpose. They did not provide the adequate protection that was required, so they were removed from circulation, and the PPE system through the national hub that was created by the Scottish Government then allowed us to access PPE for particularly social care settings at a later date, to say we need masks and we need gloves and we need aprons to be sent to this organisation, and that was then fulfilled.
We'll come to the issue of masks in a moment. You deal with it at paragraph 22 of your statement, and the subject there is quite a large part of your statement on the actual protection provided by PPE. But if we could, before we just finish on particular impacts of the lack of PPE on the social care sector, you do raise an interesting point in paragraph 20 about the use of laundry facilities. And you highlight a difference between the healthcare sector, but perhaps an inevitable difference between the healthcare sector and the social care sector in relation to the availability of facilities to clean uniforms and PPE. Do you want to say a little bit more about that?
So within that, the healthcare setting, the guidance was then created and clear that says if there is laundering facilities available, then healthcare staff can and should use the laundering facilities. We did, and we did end up in situations where, and that may be communication that we'll come on to if of time, that then became an issue that no, you can't use the laundering facilities, etc. But we fixed that and sorted that out. Healthcare staff who worked in within hospital settings that laundry services were available, they could wash their uniform so that they weren't taking it home. They weren't then going out into the community with it. If you flip that into a community setting and a social care setting, individuals were using the same uniform, going in and out of different houses, because the plastic gowns that were wearing were not suitable. They would rip. They wouldn't cover the uniform in its entirety. But they would leave one house and then go into another house wearing the exact same uniform. But within an NHS setting, that never happened. That couldn't happen. There was no laundering facilities for community staff or social care staff, so they were then having to take their uniform off, put it in a bag, and then take it into their house to wash within their own house. Obviously, there was guidance on how to do that. But the difficulties that were faced, particularly within social care settings, was the PPE that was provided did not cover the uniform in its entirety, and that same uniform is worn for the full day as you were going in and out of care homes, in and out of houses, in and out of the people that you were supporting. But within a hospital setting, that didn't happen.
Yes. And of course this was combined with the difficulty of people not knowing how COVID was transmitted.
Of course.
Yes. Well, my Lord, if we could just turn now to the protection provided by PPE and some of the particular difficulties with that, which begins at paragraph 22 of your statement, Mr. O'Connell. So you begin, you've already mentioned that, as I understand it, one solution to the lack or difficulty with sourcing PPE was to use, in relation to masks, to use tiger masks and goggles. But you then go on to contrast the differing approaches between England and Scotland in relation to masks. And this relates to the effectiveness, particularly of masks. So you discuss this in paragraph 24. Now, do you want to say a little bit more about what the difficulties were with type 2R masks as opposed to FFP2 masks?
So, in Scotland, the Scottish Government then took a decision as we progressed through that the go-to mask and the minimum standard, for want of a better expression, would be a type 2R mask, which provides greater protection than an FFP2 mask, and because there is the other mask that provided the most protection was an FFP3 mask, but the difference between a type 2 mask and a type 2R and an FFP2 is that the type 2R masks are fluid resistant and provide a greater protection than what an FFP2 mask is, although for visual purposes they're the usual kind of blue surgical mask that you put on, but there were still gaps. There would still be gaps down the side of those masks. They weren't face fitted, so therefore people were concerned that when they were in circumstances or situations where they were close to a patient, as required to do so, they would potentially be coughed, the patient would cough, etc. The particles within the air could penetrate that mask through the gaps in the side, whereas if you had a face-fitted FFP3 mask, that couldn't happen.
Yes. So what you're saying in paragraph 22 is that certainly tiger masks and goggles are of no effect at all.
Yes, the tiger mask and tiger goggles came into circulation because that was what could be procured at that time.
Yes.
But when a lot of our senior representatives across Unite are scientists, and they could obviously provide some further expertise in relation to that, and it was identified very early on from a Unite perspective that those tiger masks were not fit for purpose. They did not provide the adequate support and protection required to carry out. So the advice that was provided by Unite and later then followed by Scottish Government was not to use these masks and to bring them back and out of circulation. The difficult being that there was not a register that maintained where all of this PPE was going. It was just put out there. So it was about how do we effectively communicate to staff and members to ensure that they know not to use these masks. They don't provide that protection.
Now, in relation to the availability of FFP3 masks, they were focused on the health sector.
Yes,
yes, and that's what you say in paragraph 25.
Yes.
And you admit, or you accept in paragraph 26, that although FFP3 masks were the safest, they were limited and so couldn't be given to everyone.
Yes.
I mean, did they eventually get rolled out in the social care setting?
No, they didn't.
Another issue that you raise, which is related to the or maybe related to the effectiveness of PPE generally, but face masks in particular, is the question of it being past its sell-by date, if I can put it that way. It's out of date.
Yep.
And you talk about this in paragraph 27 onwards. So the concern here is that employees in both the healthcare and where they were getting masks, the social care sector, were being provided with masks that were out of date. Yes. And I think you say that sometimes there were in-date stickers. In paragraph 27 you say in-date stickers were simply placed over the old date.
Yes.
On the supplies.
Yes.
Yes. And Unite has photographic evidence of that.
Yes.
Yes. And what do you think the reason for people doing for people doing that was, or for?
My own personal view is that the reason that was done is because there was no other way to get the appropriate and required numbers of PPE. The reason that these dates are on these PPE is because that's the protection that it provides in terms of what is put into these masks, gloves, etc. When we then started to challenge why these the PPE supplies were then redated, revalidated, who revalidated, who done them, why did it come about, there was no answer, and initially it was, that they're safe to use. Well, respectfully, we needed that proof. We needed to see and understand for our members, why are these now safe? If they've gone over the date, they've not been recalled. There's just and there's stickers now just being placed on these and then distributed out. If they've not been recalled by the manufacturers, etc., how are they safe? What proof have you got that these are now safe?
How was this eventually resolved?
The Scottish Government civil servants, I have to say, maybe a month to 2 months down the line, provided a certificate to say that they had been revalidated, but with further investigations into that, particularly by some of those individuals are referred to have the knowledge and expertise in relation to that certificate was questionable in terms of how did you reach that revalidation point. But for our members and for ourselves, we then had a bit of paper that put the onus on an organisation or the government to say, you're now saying these are safe, but because the guidance allowed for an individual to carry out their own risk assessment and determine what is appropriate for them to wear while carrying out their duties, we would obviously advise our members to consider what that revalidation of PPE would look like.
Well, thank you, Mr. Connell. If we can move on to another issue, which the inquiry has heard about before, which is the problems associated with the dissemination of guidance and the volume of guidance. I'll take this a little bit more briefly, but you also highlight similar problems of hierarchies and effectiveness. And what you say in paragraph 31 is that there was a very hierarchical system in the way that guidance was issued and digested. So what do you mean by that?
So particularly within the health and social care sector, and I'll try and cover both here, so I think it's important. Please. Within the health sector, there would be a communication sent from Scottish Government to Chief Executive, HR directors, finance directors, you know, the senior corporate management team within the health board. That would then start to flow through their processes to say, right, okay, Chief Exec sends it to a director, director's then responsible to send it to a head of, and head of then sends it to this person, to that person, and as you start to filter through, it then gets lost in translation. Does it actually get to the appropriate person? Because the local management team that were responsible for implementing this guidance were also clinicians who were running about doing their clinical job, trying their hardest to protect patients as well. So when it then came to a situation where they were required to implement this guidance, it then became questioned or round about the interpretation of what that guidance actually says. So I think that there then became responsibilities and expectations that it was reaching the appropriate levels, whereas in practice, when you were then beginning to say, well, have you seen this guidance? The answer was coming back saying, well, no, I'm not aware of that. But I think that that's reflective of the guidance changing sometimes every hour of every day, and then how that was getting through. So you would get a piece of guidance that would then go down into the system, but then it would change. It would change an hour later, 2 hours later, and obviously you're saying, well, we need to get that back down the system to ensure that that was communicated accordingly. Within a social care setting, the government would send it to local authorities would send it out to the providers, or they would send a link to the COVID-19 page on the intranet to say, here's where the guidance is. I don't think that there wasn't a, here's what the guidance is and here's what it means and here's what your responsibility is to ensure that people continue to be protected. And when I say people, I mean patients, the people are being supported, as well as the staff as well, because it is a whole, it's very cliche, but it is a whole system approach, because I think that the important thing is to ensure that the patients and the people are supported, are protected, because they're there because they're extremely vulnerable. And I think that the application and interpretation of the guidance at that local level was where it became problematic.
Now, the guidance can cover the whole gamut of things that you touch on in your witness statement. So it can be about the use of PPE, the use and availability of masks. It can be about testing. It can be about rules on special leave and so on. Yes. Yep. And quite a lot of the and also the impact on pregnant workers. Was there any guidance on that?
Initially, there wasn't any guidance on pregnant workers. I think that this is really important to recognise, because initially when this situation started to break, understandably so, expected parents, expected mothers were concerned for their unborn child and the impact that COVID could have on it. Mm-hmm. So what should be happening for pregnant workers is a continual risk assessment, continued recognition of what stage they're at within their pregnancy and the impact that may have. Because of the lack of guidance and the lack of understanding, it was, well, you could
If I can ask you just to pause there, my lord, if we could just look at paragraphs 49 and 50 of the statement. So we're still on the issue of guidance, but I just want to drill down a little bit on the initial guidance, if there was any, and the changing guidance in relation to pregnant workers? So we're talking about the initial guidance.
Yes, initial guidance, there was no specifics round about pregnant workers, but as we progressed through, it became apparent that pregnant workers should not be in a situation where they could come into contact with individuals who are COVID positive. So if you were in a COVID receiving ward, if you were in intensive care, if there was potential within the community that because you don't know what you're walking into, etc., then the impact on a pregnant worker was as such that you should not be there. We should be looking at alternative duties. We should be making sure that you're protected and that your unborn child is protected. Initially, that was not the case. That didn't happen, and there was an expectation that pregnant workers would continue as normal, and that they would come to their work and they would do what they would normally do, despite the fact that the concerns from expecting parents and expecting mothers was as such to say, this could have a detrimental impact on my unborn child, and I'm extremely scared. I think I'm scared. I feel vulnerable for my child, and an expectant mother is that's their priority. But the unintended conflict or requirement to do that is, but the guidance doesn't say that. So therefore, you need to come to work, then put things in place where we know that there were members that were the stress and anxiety that caused. They then removed themselves from the workplace.
Was there any difference in relation to the approach to pregnant workers between the healthcare and the social care setting?
Initially, no. I think that.
But eventually, did it change at any point?
I think that the pregnant worker guidance became quite known. I think personally, I think that it was disseminated out there to ensure that. And I think was that general guidance, or was that guidance for a healthcare or a social? It was general guidance, right. Through because the guidance that was presented for pregnant workers related to all pregnant workers. But I think that the important bit to note on that was how was that disseminated and how was that then reflected within practice, and particularly within social care, because they potentially didn't have the same access to the guidance as a healthcare centre would, because of how it was sent out. Yes.
Returning to the effectiveness of guidance in paragraph 32 of your statement, although you're talking about FFP3 masks, what you say there is that local managers often advocated that FFP3 masks were only required for staff working in intensive care. Yeah. But even there, you think the guidance got lost in translation?
Yeah, because an FFP3 mask is face fitted. It needs to be face fitted to you so that it is tight. I think from people explaining to me, they are not comfortable to wear. They are not something that people would be actively saying, please give me one of those masks because it's really comfortable. They were asking for that mask because that is what gave them protection. The guidance that I referred to in relation to how that was being interpreted, the guidance was clear that if a worker carried out their own personal risk assessments, which they were advised to do, and requested an FFP3 mask, they should get one. But because they had to be face fitted, what local managers were saying is, you can't get an FFP3 mask because you're not fitted for it, or you are not required to wear one because you do not carry out an aerosol generated procedure, which creates its own issue. But staff could have requested an FFP3 mask as they so wish.
Yes. You deal with aerosol generated procedure in paragraph 33. Can you briefly explain what that is?
Yeah, it's particularly within COVID receiving wards, within ambulance service, with when chest compressions, etc., that creates an aerosol generated. That is an aerosol generated procedure. It creates the molecules coming from mouths, etc. But if you take a speech and language therapist who, for example, that carry out a specific duty round about people's throat and put tubes in throats, that the liquid and the generation of those is created, but that was not determined as an aerosol generated procedure, so therefore speech and language therapists did not require an FFP3 mask, despite it doing that. If I can, I think it's important to recognise that individuals with from a specific ethnic background, or they have specific religious beliefs, could potentially, it would have been difficult for them to wear an FFP3 mask because of facial hair or headscarves. And I think it's important to recognise from a Scottish Government perspective and from a trade union perspective that that was fully respected and understood, and that if that was the case, then an individual was then there was alternative sought for individuals to respect their beliefs, or they were removed from that particular area, so that there was a respect of individuals' beliefs, etc., which I think is an important impact on that human right of the individual.
Well, thank you. If we could just turn to just one or two issues around testing. You talk about, in paragraph 38 and 39, you talk about the rollout of testing was important in terms of helping to protect people. But an issue was the complete reliance on testing despite the acknowledged lag in time between when a person became symptomatic and when they actually tested positive. We touched on that before. But you make the point that in paragraph 39, in terms of contact tracing, employers often insisted that identified close contacts continue to come to work.
Yes.
Is that true, again, both in the health and social care setting, or more one than the other? I
think there would be more in social care, if I'm being honest. I think that because of that, there's very slight delay that if you are identified as a close contact and test, there was a potential for you to test negative for the first day or two, and then you would test. But whilst you may have been testing negative, you had potentially contracted COVID. I think that it was more prevalent within the social care setting, not so much healthcare, because I think within a healthcare setting, if you were identified as a close contact, then you would have received full pay. You would have been told, go home, isolate for 10 days, and you do what you need to do. Within a social care setting, that was not the case. There was a lot of difficulties with accessing funding. There was a lot of employers, because they did not receive the money from the Scottish Government, then they would say, well, actually, we can't pay you if you are required to isolate for those a number of days. But the test was then became the key. It was like, are you testing positive? No. Well, you've not got COVID, so you can come to your work. What that did is it put the individual in a very difficult, vulnerable position because they had been identified as a close contact. They were going into the workplace or going into support an individual that could have had devastating effects on the individual if they had contracted COVID. But if they'd stayed off, they wouldn't have been paid, so therefore they're in a situation because of the way that social care is set up and the pay, that issue then exacerbates things for them and continues to stress.
And are these inconsistencies a result of lack of guidance, or or wrong interpretation, or conflicting interpretations of guidance, or
I think all of the above, but at the same time, I think that it also comes down to the construct of the contracts in terms of, because of what was happening within across the Scottish Government and what they were trying to do in supporting particularly public sector and social care, that organisations and employers were reluctant, and they wouldn't pay people fully until such times that they knew that the Scottish Government were going to pay for it. So it was more about what was their budget and what's their bottom line.
And the problems are similar in relation to COVID special leave, as you discussed them in paragraphs 42 onwards of your statement. This is again, there's a difference of approach between the healthcare sector and the social care sector in relation to how COVID special leave worked.
Yes, and as I articulated previously, it's the same principle, that within a healthcare setting or even a local authority setting, people were off and they were fully paid. As you start to go into your community youth, not-for-profit, third sector and charitable providers, that was not the case. And so much so that as we progressed through coming out of the pandemic and I'll use the words come back to normal, because I can say that people within this sector are not back to normal. It still impacts them to this day. Health and social, the health sector maintained COVID special leave so much longer than what a social care provider did. I think COVID special leave only finished January this year, December this year, within a social care provider setting. That was long gone.
You've got 10 minutes left, Mr. Edwards.
Thank you, my Lord. There's just really two main issues that I want to touch on. Very briefly, vaccinations in paragraph 45 to 48. There's two issues there. I just ask you to comment briefly about. I mean, the first is a hierarchy issue again, which we've touched on before, that it's higher priority staff and lower priority staff.
Yes.
And I'm assuming that social care staff would be in the latter category rather than the former. Is that correct? Yes. Yep. And then in paragraph 48, briefly, you say that there was conflict between UK-wide organisations and, if I can put it this way, devolved organisations, in that there was conflict between who needed who required a vaccine to come to work and who didn't.
Yes. So
what was the impact of that?
Within Scotland, there was a recognition that it's choice for an individual whether they receive a vaccine or not. It was not mandated in Scotland that you must be vaccinated, whereas within England it was mandated that you need to be vaccinated. Where the conflict came was as if you had an English employer who were based in England would then be operating within Scotland, that there would be an attempt to apply the England position in Scotland, despite Scotland having a different approach. So it then got to a stage where our members were then threatened with disciplinaries, dismissal, if they did not go and get vaccinated to ensure that they were able to do their work. When we raised that directly with the Scottish Government were clear that if you are in Scotland, operating in Scotland, then you will be bound by the Scottish Government guidance, and that guidance was that it was not mandatory to be vaccinated, and I would suggest that even to this day there are people who have not been vaccinated because that is their choice to do so, and I think that the Scottish Government respected that choice and gave the individuals the opportunity to determine for themselves.
Yes. Reporting COVID in the workplace, very briefly, in paragraph 55, you talk about the union's concerns in relation to employers' reluctance to allow COVID transmission in the workplace to be reported. That was true both in the NHS and in the social care setting, was it not?
Absolutely. I would say that probably even more so within social care, because of the mechanisms that exist within health. There was an opportunity to do so, but refused. But even more so within social care, that mechanism may not have existed.
And I think the reason for that, I don't want to put words in your mouth, but a reason for it was concerns about liability.
Potentially.
Finally, before I ask you about lessons learned, you talk about the definition of key workers. Yes. And that is a difficult and still a sore point, I think, between the healthcare and social care settings. Yes,
I think that the definition of key and essential workers, and I think that it's important for me to applaud, support, give every word I possibly can to thank the individuals who day in, day out came to their work, who, whether it be supermarket workers, whether it be waste services operatives, and importantly health and social care workers. Without those individuals, who knows where this country would be. We're forever indebted to them and the work that they've done. But the £500 COVID bonus that was announced at a political party's conference was not discussed, not suggested, nothing. So we had all of this workforce leadership group who decided guidance, discussed everything. This came out of the blue. And it's commendable to recognise the work that individuals have done, but it was incredibly divisive. Because you then have a situation where you are determined as an essential worker and you need to come to your work, but you're not a key worker. And there is a distinct difference, because the COVID bonus, every single person working in the NHS received the COVID bonus, every person. You then go into a social care setting, not everyone received the £500 bonus, but they were required to be at their work. If you then go into, and I know this is focused on health and social care, but it's to demonstrate that disparity, Mr. Edwards, is that the waste services operative, the people who pick up our bins, were determined that they must be at their work. They need to be there. You have our building services operatives who go into people's homes to ensure that they are heated, you ensure that they have running hot water. In emergency situations, those individuals were just as vulnerable as others, because they were going into households. Those individuals were not. It was not applicable for them to receive the £500 COVID bonus, despite them being out every single day the same way everybody else was, despite the work that they were doing was to ensure that this country functioned and continued to operate as it did. So therefore the divisive nature of the £500 bonus then became an issue, and particularly within social care, where you have what's determined as frontline workers, so people who come into contact with the patient or the individual. They received the bonus, but support staff who are integral to ensure that that support is provided didn't receive the £500 bonus.
Yes. You talk about divisive. Divisiveness can have a legacy, can't it? It can.
Indeed, and it still is, particularly when, you know, we discuss, we touched on the committees, etc. But within Unite, when you're talking about pay claims, when you're talking about all these things, we still have members saying, well, it wasn't appropriate for me to receive the £500 bonus, so how can you use the type of work that I do and classify it in such a way when it suits you, but when it doesn't suit you, i.e. to pay me £500 for the work that I've done throughout COVID, I wasn't as required, or wasn't.
So I mean, that sort of legacy, if you like, takes us to the last point. Towards the end of your statement, you talk about lessons learned. I mean, if you were to identify 2 lessons that you would hope to be learned from the pandemic, what might they be?
For myself, I think that my reflections is particularly around about how prepared we were. I talked within my statement that the Scottish Government had already carried out pandemic preparedness that identified that we weren't ready for a pandemic, that we weren't ready if, God forbid, it ever happened. And the frustration for me is that is gathering dust on a shelf instead of actually actioning what was in it. So if we are going to, and we are going to learn lessons, it should be that if you're going to carry these things out and it identifies that there are issues and there are concerns, then we should be seeking to resolve those issues and concerns so that we are prepared for that. I think that's extremely important. I think the other element for myself is, particularly within social care, is to learn the lessons of the interaction with the trade unions that happened, particularly within the health service. You know, we done everything and we could in the relationships that we had within the health sector to address concerns at a very early stage. Within social care, that doesn't exist. The government have committed to collective bargaining, sectoral bargaining within social care, and committed funding to it until a couple of weeks ago when they removed that funding. So that becomes an issue. I think that as a society, particularly within social care, we need to ensure that the individuals within social care are better protected, because they're not, and we should be learning from how we managed to achieve some of the positive outcomes from a healthcare perspective, which then slowly but surely rolled into social care, but are now being lost because it is back to normal situation. We need to be really concentrating on social care. We need to be concentrating on the value that social care workers and that whole sector provide to our country.
Well, Mr O'Connell, thank you very much. Your evidence, your statement, sorry, and your evidence will stand as a whole before the inquiry. I want to thank you for what has been a very clear and sophisticated, detailed elaboration of your witness statement, and I'm very grateful for that. Is there anything else you would like to add before I conclude?
No, just that I think from myself, I think it's important to re-emphasise that as a country we need to be extremely thankful for what every single individual provided to ensure that patients, the people that required support in our country, continued to operate the way it did throughout COVID, because without them, who knows where we would be, Chair. Thank you.
We can certainly all agree on that.
Thank you.
Thank you, Mr O'Connell. Thank you, my Lord.
Thank you, my Lord.
Yes, thank you, Mr O'Connell. Very good. 12 o'clock for the next session. Now, good afternoon, Mr. Stephen.
Good afternoon, my lord. The next witness is Peter Hunter.
Good afternoon, Mr. Hunter.
Good afternoon, my lord.
When you're ready, Mr. Stephen.
Thank you, my lord. Could you confirm your full name, please?
Peter Matheson Hunter.
Thank you. Your age and contact details are known to the inquiry, so I won't ask you for those. And you've helpfully provided a witness statement already in writing. For the record, the inquiry reference number for that is SCI-WT 0478-5 zeros and then a 1. Are you content for that written statement and the oral evidence you give today to form your evidence to the inquiry?
I am.
Thank you. And you're happy for that evidence to be recorded and published?
I am.
Thanks. And everything you say in that statement will be taken into account even if we don't touch on it in oral evidence today.
Thank you.
And the last reminder just before we begin, there is a restriction order in place, so please don't name any specific individuals when you're giving your evidence.
Okay.
Thank you. I understand that you're employed as a regional manager with UNISON, is that right?
That's correct, yes.
Which region is that?
So the Scottish region.
And what that covers the entirety of Scotland?
So yes, within our structure, Scotland is a region, and within Scotland I cover the north of Scotland, so pretty much from Perth, Dundee, northwards, Highlands and Islands, Aberdeen. And then there are functions that I cover within the organisation, the legal service, the education, the equalities function, and various other. It's a complex structure.
And how long have you held that particular position for?
9 years now.
And how long have you worked with UNISON more generally?
I joined in 2001, so 23 years.
Thank you. What is the size of UNISON membership in Scotland, roughly speaking?
163,000 people.
I understand from your statement the bulk of those members are in local government, is that right?
Approximately 90,000 in local government, and so there would be some care services within there, children's residential care, social care that's delivered in-house by local authorities, and then between 15 and 17,000 social care workers in contracted services, and then perhaps 40,000 NHS workers. Anxious the arithmetic might not add up there, but broadly speaking.
Thank you. And in sort of high level terms then, what is the role or function of UNISON in assisting these members that you have?
So we look after people as individuals, so from their arrival within public services through access to apprenticeships and training and progression, and many employees take advantage of our learning facilities for continuing professional development or for their career progression. We look after people as individuals if they get into difficulty in relation to grievance or disciplinary matters, and then collectively we negotiate the pay and working conditions for employees, so their annual pay rise, their grading structure, equal pay between women and men. For specific groups we negotiate equality arrangements and strategies for entire groups, so I'm particularly involved in work that we do with the black workers within public services in Scotland, but also I coordinate our equal pay work, which has been a big and time-consuming and very litigious area of activity for us to change systemic inequalities between groups, separate from that which we can achieve by negotiations. So it can be individual, it can be collective, it can be by occupational group, by service, or it can be by communities of interest, young workers, older workers, women, black workers, disabled workers.
Thank you. I'd like to take you back now to the start of the pandemic and the impact, I suppose, on UNISON. In paragraph 31 of your statement, you talk about the importance of the union having a democratic mandate and having to create, during this time of virtual democracy, I think is the words that you use, following this move to operating in an online environment because of COVID. How did you go about doing that as an organisation?
It was a challenge. I mean, I would be critical of public sector organisations for not having long-term plans for the pandemic and then for not being alert to the immediate implications of what was happening in China January, February, March. And the same criticism could be directed at us. We didn't have long-term plans, and we sat looking at hospitals being built rapidly in China without thinking that the same challenge might await us. So we had to very rapidly create arrangements by which we could support members to continue to work in the way that we traditionally work. There might be a stereotype of trade union barons like me intervening aggressively and without a mandate on behalf of workers to create trouble. That's not my experience of UNISON. We are precisely the reverse. I like to think I have a relatively low public profile. We support members to do things in their own name, which is the slower and more cumbersome way of doing things, but we think it's ethically the correct way to do that. So that involves adult education, skills training in relation to workplace advocacy, and in particular support for disadvantaged groups who might not automatically have access to and progression within workplace arrangements, so younger workers, disabled workers or women. And so to maintain those arrangements during the pandemic when nobody is meeting in person, then we have to have training programs to bring people through and virtual meeting spaces for people to prepare for engaging with the employer, and then virtual spaces for the meetings with employers. And I would say, notwithstanding our relative lack of preparation, we did that well.
Thank you. And you mentioned education there, and you said at the outset your own role involves that. How did you adapt your educational programs? I think I saw reference in paragraphs 39 and 40 of your statement to hiring of an American organisation to help you with that. Is that right?
We did. So there was one of the features of American industrial relations is that some of the trade unions are systematically excluded from sectors of the economy, so they work online. And we thought it would be a good investment to benefit from their skills and experience, and we hired them, and that was very helpful. In relation to our own adult education programme, we're very keen that it be member-led. So we survey members about their needs, which very often are about literacy skills, digital skills, cybersecurity, and there was a massive shift. Workers wanted to know about COVID, they wanted to know about safety, they wanted to know about bereavement, trauma, stress, and coping with mental health. So our adult education programme moved from literacy and numeracy and personal development to mental health awareness, trauma awareness, trauma-informed practice, through to the point of creative writing to help people process the experience that they were going through. So that was the adult education work. More specifically in relation to the technical side of our work, we had obviously an exponential rise in the need for health and safety reps. So we would organise drop-in online sessions, maybe in the early evening, where people could come and ask questions and get into conversations about the new COVID safety environment. And from those conversations, or from social media based survey questionnaires, we identified people who might step up to not be a full health and safety rep, but very specifically a COVID safety rep. So we weren't teaching them control of substances hazardous to health or manual handling. We were focused very, very specifically on a syllabus in relation to COVID. And hundreds of people volunteered for that, and then were deployed by us either virtually or in real life, both during the pandemic and in the return to work. And I would say that the colleagues, unnamed, who delivered that programme and the volunteers who participated in it did an exceptional job.
Thank you. And you talk in your statement of having to be innovative in communication because of what was happening. And I think one communication tool in particular you referenced in your statement at paragraph 42 is the use of surveys. And you touched on that there. When were these surveys carried out, and what was the size of the sample that you were getting back?
So we were surveying quite regularly, and sometimes the surveys were to gather detailed information for dialogue with employers. So we were very concerned from the start of the pandemic about the disparate impact on disadvantaged groups. So in our experience, the people who were able to work from home tended to maybe be middle class, maybe disproportionately men, disproportionately white, whereas frontline social care workers or cleaners, not exclusively but disproportionately black or ethnic minority or lower paid working class women. And we were very concerned to read that, I forget the precise percentage, but something in the region of 3/4 of the deaths amongst clinical staff at the very start of the pandemic were from a black or minority ethnic background. And we were very keen to find out what, from our experience, what might be contributing to that. So that was more of a policy survey. Sometimes we would use a shorter 2 or 3 question survey. Are you concerned about the pandemic? Do you feel supported? Would you like more information? And that's more of just a method of contacting people and building the relationship, perhaps to see who might want to then receive information, share it with their colleagues, and possibly become a COVID safety rep.
Thank you. And yes, you mentioned sort of the differences perhaps between, say, black or ethnic minority workers and others. And I was going to come on to that because you talk about that in paragraphs 44 and 45 of your statement about the survey results on that issue. What do you attribute those differences to? You mentioned perhaps the nature of your employment, or what would be your answer to that?
So our concern was that this debate was being pathologised, that in some way that black and ethnic minority workers were inherently less healthy and therefore more susceptible to either infection or disease arising from infection. And we were intrigued to see whether there was any evidence for that or whether or not there were structural factors. So the type of work that people were doing, the data was coming out from government about infection rates and death rates in particular occupations, and it struck us that there were particular jobs which, by virtue of the frequency of the contact with the public, were more susceptible to infection, and that within particular aspects of the economy, that the level of protection, for example, in contracted care or health services might be poorer than it was within the NHS, which might have more elaborate employment systems. And we were keen to establish what that was, and generally speaking, we found some evidence that our membership were disproportionately in sectors where our presence was weaker, where there weren't health and safety reps, where the safety culture was poorer, and they also expressed a fear of reporting hazardous working arrangements, and in some cases victimisation or reprisals for any whistleblowing that occurred. And we saw these as being potentially significant factors that should form part of the wider debate.
And did you publish those findings? And so was the Scottish Government aware of those findings?
Scottish Government were aware of those findings, and we pushed government on them and the NHS. From memory, we agreed some guidance where black workers could have a personal risk assessment, which was helpful. And there was a continuing debate. There were working groups set up. We were able to populate those working groups with our own workers, not me, but with workers who had participated in the design of the questionnaire, the analysis of the results, and they then sat on those working groups with government and employers to seek to improve the position of black workers, particularly those who felt more vulnerable. So that was, I think, productive in terms of raising the profile. We did have a specific case where there was a worker who raised concerns about their safety, and they were absent from work and they were dismissed. And we provided the employer with a copy of the research to say it is understandable that a black worker in the current situation should be stressed and anxious about the risk that they face over and above the baseline anxiety of all workers, and that the employer should review their decision in light of that evidence, and the person was reinstated. So that's a microscopic example of the type of thing we were looking to achieve.
And those working groups that you mentioned earlier, were they running throughout the life of the pandemic? Was it an iterative process in terms of the feedback you were giving?
They were. So there was one hosted, there's an organisation called BEMIS, which is Scottish Government funded, multi-party, multi-agency approach to race equality, and the Equality and Human Rights Commission did their own inquiry into the issues that we had raised, to do it in a level and a depth that we weren't able to, and our people participated in those processes. There was a degree of hyperactivity at the time, I think possibly as an outlet for the stress that people had. It wasn't uncommon for emails to start moving around at 5:30, 6 in the morning, meetings to start at 9, and then continue on until 8, 9, 10 at night. And many of these people were unpaid public sector workers who were doing these projects as a voluntary commitment.
I want to move on now to, you mentioned health and safety, so I'd like to move on to that and PPE in particular. In paragraph 55 of your statement, I think you say in terms of health and safety, you describe being required to go from the normal standard to the Olympic standard overnight, I think is the way that you put it. In your view, where was the social care sector on the list of priorities for access to the supply of PPE?
Well, generally, in health and safety terms, within health, local government and social care, then third. Within the supply chain for procured PPE, third at best. And generally speaking, my perception and my reflection is that the Clap for Carers movement stemmed out of a realisation collectively that there are these people who perform a vital role in society generally, who are now particularly vulnerable. So we're only now realising how valuable they are and how vulnerable they are, and we need to celebrate them because, notwithstanding the fact they've been overlooked and undervalued in the past, they are now in the front line on behalf of all of us, for our loved ones, but also for the spread of the disease generally. And I think that reflects the fact that social care, elderly residential homes, but also care at homes, care at home or home care services, and other social care functions for disabled or vulnerable people in the community, that vital work had been overlooked and was suddenly now recognised as being as crucial as it has always been, but now crucial and vulnerable in the context of the pandemic.
Thank you. Specifically, what was the feedback you were receiving from members as regards the availability and the quality of PPE being provided in the social care sector?
Excuse me.
Take your time.
It's kind of being taken back to the moment of sitting at home and being in meetings with workers in extreme distress and being unable to help them, and being unable to advise what they can do, and their very evident trauma arising from the realisation that the infection is out of control, that they are being required to continue to work in care roles, knowing that they're exposing themselves to infection, fearing that they are bringing infection to the person who they are caring for, and the dissonance between that. I am paid to care for you, but I might be bringing the infection that kills you, and the inevitability that in some cases that did. People's knowledge of the fact that despite the lockdown restrictions, they were going to work, coming home, and their family had become infected, quite possibly by them, or family members had become infected, they'd continued to go to work. Service users and service user family members had become infected and died. processing with and living with the reality of that was visibly traumatizing for our members in a way that I will never forget. And in that context, to have people ask whether or not it's appropriate to receive one single-use mask at the start of the day and be required to use it until the end of the day, and knowing that the answer to that is no, but that there's no solution to that, is beyond frustrating. To be having conversations with people saying, well, I just got bin bags and cut them up and wrapped them around myself. I wore my Wellingtons, or I used marigolds, and the various other improvised PPE that people were required to use. In all that time, I don't remember an NHS nurse contacting us with that level of distress, or with examples of the extreme improvisation that social care workers were forced to adopt in order to do the best that they could to keep people safe. It didn't happen in the NHS in my experience, it didn't happen in local government, but it was prevalent in contracted services.
Thank you. And I wanted to ask you also about out-of-date PPE. Did you get any feedback from members on that being used or recommended that that be used?
The supply chain problems, so there was a lack of supply. So we had PPE kept under lock and key. PPE that was only available if the worker reported that their service user was symptomatic. And then getting into arguments with employers around whether that was too little, too late. There was examples, so the adequacy technically, so some employers were purchasing masks that were designed for other purposes, or gloves that were designed for other purposes. So did the particular piece of equipment fit the specification contained within the government guidance for that setting? Spent an inordinate amount of time hearing reports of the equipment that had been given, looking at phone images of equipment that had been issued, checking it against the guidance. And the efficacy of the advice we were giving on those, specific points, was a B&Q DIY paper mask as helpful as a genuinely medically designed single-use PPE? Who knew? So there was issues about the quality, the timing, the volume of supply, the repeated use, the cleaning of PPE and the reuse of PPE, staff being instructed to retrieve PPE from the bin, clean it or leave it so that the infection risk would subside, and then reusing it. Looking at it as an end-to-end business process, there were weaknesses, potentially fatal weaknesses, at every stage. And those inquiries were far more common in the independent contracted service than they were either in the NHS and local government. I mentioned the example in Glasgow City where we had 2 days of debate with a large West Coast local authority about the adequacy of PPE supply. And we thought, well, we won't agree to our people working if there is no PPE, and spent a bit of time preparing how to communicate that to the employer. And the employer's like, no, if there isn't adequate PPE, we'll suspend the service, don't worry. And that's an entirely different conversation than the ones we were having with contracted social care services.
You used that word weaker, and I saw it in your statement in several places. At paragraph 59, you described the private, voluntary, independent sector as systemically weaker, I think is the way that you put it. Why do you use that description to describe that sector as systemically weaker?
Well, so first of all, as a preface, I would say that there are organisations, in my experience, in the independent sector who deliver exceptionally high quality services, who are very open to progressive employment relations, who work with us. But structurally, Those services are procured from the independent sector in order to drive costs down. We no longer talk about compulsory competitive tendering, but that's what we do without using the name. And therefore, organisations are compelled to work to a different cost regime in that sector, whether they like it or not. And our experience is that we could have far more effective employment relations in that sector, and we know that consensus exists if the funding was adequate. And the consensus relates both to the pay and conditions, but also the safety cultures that would exist. So it's a cost problem, and it manifests itself in different ways. Influence and purchasing power within the procurement supply chain is just one dimension. I think there's an analogy with the oil industry here in relation to what happened offshore before and after Piper Alpha. And in that sense, and it was my experience, bizarrely, that the start of the pandemic was not unlike an explosion, which it shouldn't have been. It was a gradual spread of an infection from China, but the impact of it was as if it had this sudden impact of an explosion because of the lack of preparation, and people were looking at the wreckage of public services to see what could be improvised by way of mitigation strategies. So the reason I say that there's an analogy with offshore is that the offshore oil operators prior to Piper Alpha said, we don't need trade unions, we don't need the Health and Safety at Work Act, we want our own arrangements. People offshore can join trade unions if they like, but they don't tend to. We're not against trade unions, they just don't happen to join. We'll make our own health and safety arrangements. And that is the culture in independent social care. And I think the Cullen inquiry correctly identified that it's not the technical knowledge about offshore safety that makes trade union representatives particularly valuable. It's the culture around which their observations are made, so that if a trade union safety rep says the system's not safe, they've been trained, they have awareness about how to do a risk assessment, about the adequacy of the information and training that's required to go to colleagues to have a safe culture as well as safe equipment, but then the slightly higher degree of confidence that if they petition management and say the social distancing is breaking down here or the PPE is not adequate, you can never eliminate victimization of whistleblowers from any system completely, but it is less likely in a trade union environment where people are supported than it would be without trade unions. So it's a cultural point that I'm making, that the independent contracting sector is a systemically and culturally weaker safety practice than we get in the health service and in local government.
Thank you. And at paragraph 60, you go on to describe the decision to discharge patients from acute settings into, as you've described it, the weaker part of the system, i.e. those with poor access to PPE, as the ingredients for disastrous problems. And you say in that paragraph that this was entirely foreseeable. So the question I'd ask you is that that's your view. Do you consider that the Scottish Government should have foreseen that this would be an issue?
Yes. The reason I say yes to that is because it's obvious. Secondly, the Fair Work Convention reported in February 2019 that the poor employment conditions in social care were not just bad for the workforce, but were contributing to the crisis in care because the sector could not attract and retain either the number or the quality of staff required to meet increasing care demands or to raise the quality of care within the contracted care sector. And government accepted that report, I believe in good faith, and embarked on Fair Working Care Implementation Programme, which they were working with us in January 2020 when the pandemic broke. So I would say that was recognition that there were systemic weaknesses in the sector which were affecting care quality generally, and implicit within that is safety. I don't know what alternatives government had. The pressure that was predicted for acute settings was enormous. They wouldn't have built the emergency facilities, the Nightingale hospitals, were that not the case. The pros and cons of spending time and money giving the Scottish Nightingale hospitals a different name from the English Nightingale hospitals, I think, is symptomatic of a need to be slightly Scottish in relation to everything that we do. I think that was perhaps trivial, but symptomatic of one of the focuses and the priorities in government at the time. I don't think there was a ready solution to the anticipated crisis in acute settings, but that point, notwithstanding that point, the likelihood that there would be an adverse consequence of moving people from safe settings to settings that were known to be less safe, and for me was obvious.
I want to move on now to sick pay. It's an issue you highlight in particular at paragraph 64 of your statement. Why was that issue being raised by your members during the pandemic?
So, members would quite often come to us having had a difficult conversation with their employer on differing levels of tension or difficulty, whether to work or whether not to work. Sometimes they thought they should shield and the employer was saying, no, you shouldn't shield. Sometimes they thought they should isolate because they'd been exposed. They'd been told by the tracker that they should isolate, and the employer was saying that they should work. Sometimes they were saying that they should isolate or be absent on grounds of poor health because they were tested positive, and the employer was compelling them to work. One element within that debate was the fact that in contracted services, the culture is not to pay contractual sick pay. That's the norm within the NHS and within local government. So on average, a person who is absent for reasons of sickness in health and local government will get £600, £575, something like that per week as their contractual wage. In contracted services, it's statutory sick pay, day 1, 0, day 2, 0, day 3, 0, day 4, £22, day 5, £22. So it's a drop from whatever their normal weekly wage is to £44 per week. And that was a very unhelpful structural feature of the market, which compelled those people who were in poverty or who had debts to service, which would nudge them towards working when track and trace was saying isolate, or a positive COVID test was saying isolate. The Scottish Government responded quickly and effectively and set up what we referred to under the coronavirus emergency regulations 2020, set up what we called the COVID sick pay fund. They didn't have the devolved power to pay sick pay or compel employers to pay sick pay, but they could set up this fund and encourage employers to pay contractual sick pay to make sure that people didn't work wrongly and then reclaim the money from the fund. That was helpful. There was then a commitment that that would be continued permanently as a safety feature in the sector for good. That was welcome. Some employers said, no, we have a company policy of not paying contractual sick pay. If we pay it in Scotland, we will have to pay it elsewhere. We will not access the fund. So that it's like government creating a reserve of PPE in order to raise the quality of safety on the ground. And the employers saying, no, we would rather be unsafe. And for me, that's a terrible example of how the contracted social care market is structured in a way that tips equity-backed, profit-orientated companies to place greed over need, to place profit over safety, and to contribute unnecessarily and avoidably to infection rates and deaths.
So are there particular lessons to be learned then? You touch on these in your written statement, but any you would like to highlight to the inquiry based on what you've just said as regards, well, sick pay?
The lesson was briefly learned in that the fund for sick pay was set up. It stayed in the memory of politicians for a couple of years, but in my view, it's my evidence, that the pressing and political imperative for a council tax freeze in the autumn of last year meant that the fund to create a permanent contractual sick pay entitlement and to have that safety legacy from the pandemic was dropped. So we are now in a situation where workers are back on statutory sick pay, and if we have a resurgence of COVID, that's a problem. In relation to conventional ordinary winter flu, that's a problem. Norovirus, any number of other viruses which potentially infect and kill vulnerable people of all ages, but particularly the elderly, there is a proven beneficial intervention which was adopted and has since been dropped. So if I am asked whether or not the lessons of the pandemic have been learned, my answer is no. If I am asked whether or not I look back on Clap for Carers and think that that sentiment was sincere, my answer is no.
So in your view then, what could or should be done differently if, as you put it, the lessons have only briefly been learned or not learned? What can or should be done?
Stand by the commitment. Either the £37 million investment in sick pay during the pandemic was unnecessary, and it didn't create a material change in the safety of vulnerable elderly people, in which case the debate about sick pay is about equity for contracted service workers against their comparators, or whether or not we can deliver it through our traditional trade union muscle or litigation or whatever else. If we're going to have it as a sensible, mature, adult conversation about a lesson from the pandemic, something that survives after the applause, which says we were ill prepared, but we learned quickly and we've embedded it for the future. Pay sick pay now.
Thank you. I want to move on then briefly to shielding. Paragraphs 88 and 89 of your statement, you describe shielding as a bold move and that broadly speaking it worked quite well but was not without its difficulties. And you mentioned earlier that you carried out various surveys. Are there any particular difficulties or again lessons learned on shielding that you would highlight to the inquiry?
So I'm reflecting as I speak about the fairness and the compassion I am or amn't showing towards the political community. Their long-term planning was poor. Their short-term planning between January and March 2020 was particularly poor, as was ours, as was everybody's. In fairness to the Scottish political class as compared to the English political class, we didn't routinely go around hospitals deliberately shaking people's hands, which is a marginal gain, but it's an important public information message. On relation to shielding, my perception is that falls in the class of very welcome, rapid improvisations. We have medical data, we can sift that data quickly in relation to the adverse impact of the coronavirus on an underlying medical condition. Let's communicate with these people quickly and say that, you should shield until we get a better sense of what's happening in the pandemic. So I think that was very effective. Generally speaking, the majority of employers public sector, health, local government and contracted services responded to that positively. The difficulties were around the margins, and those were particularly intense conversations because everybody was anxious. But those people who had underlying conditions which told them that either they should shield for themselves or particularly to shield for children, those were amongst the most traumatised and traumatising advice conversations that I've ever had or would want to have. And people quite commonly resigned their job rather than comply with an instruction to work if they felt that by working they would be putting their loved ones at risk. And we shouldn't have to be having those kind of conversations, not when it's avoidable.
Thank you. The last topic I wanted to ask you about was that of guidance, something the inquiry's heard a lot about. At paragraph 100 you described there being constant tweaks, I think is the way you put it, to the guidance being issued, and a danger of getting lost in it all. And you also talk about information often, say, coming out on a Friday and then having to be, studied over a weekend and then cascaded to your members in a rush, I think is how you put it, paragraph 102. I suppose two questions I had for you. Firstly, was UNISON consulted by the Scottish Government on these tweaks, as you put it? And was this a useful or helpful way, in your view, to disseminate this guidance?
It was. I suppose that's perhaps more of a personal gripe about the experience. We were, although I've been critical of many organisations and institutions in what I've said this morning, government were very inclusive and approachable, and we had phone calls from cabinet ministers after a live meeting. We were concerned about your colleague. He seemed to be particularly stressed. That doesn't happen now, but it happened then. So they were good. They moved quickly. They were agile. They were engaging. I suppose it's a marginal point about. I think what was going on psychologically was that the economy's bordering on out of control. The health system's bordering on out of control. Some of the social protests are bordering on out of control. Let's tinker with the things we can tinker. Should it be 3 metres or 2 metres? To be honest, I think the marginal gain of some of those that tinkering wasn't necessarily worth the effort that went into it, but it didn't do any particular harm. But longer term, in terms of whether or not there's a risk of compliance fatigue, I think a degree of consistency and stability in the guidance is something that's worth thinking about. But there'll be behavioural psychologists who'll give more robust advice on that than me.
So put another way, perhaps control the things that you control or feel like you can control. Control
the things you can control, but don't just twiddle with the dial because it's the only dial that appears to work. There became a bit of a fixation about, would Scotland go from 3 metres to 2 metres? And at the end of the day, in the scheme of things, given some of the big structural factors which I've talked about, so take somebody from a safe acute setting and put them in an insecure contracted care setting, whether the staff were 2.5 metres or 3 metres away, didn't make any difference.
Thank you, Mr. Hunter. I don't have any further questions for you. Grateful, obviously, for your evidence, both in writing and today. Before we conclude, was there anything in particular you'd like to mention or that we haven't covered or talked about?
I suppose I'd just briefly return to what I see as the analogy with Cullen. I think that, with the greatest of respect to public law, the judicial community, and there are some inquiries that have had a lasting impact. Dunblane, Cullen. And there are other inquiries, frustratingly, Macpherson, systematic or institutionalised race discrimination, which have the ambition continues to elude us. I think looking at social care, there is a moment here where the inquiry can't anticipate the grade of PPE that might be required the next time a particular virus affects us all. But I think if social care were reviewed and if we were respected and seen as being responsible participants who can help improve the culture, so we might not necessarily guarantee access to the right grade of PPE, but we can bring the training and the confidence and the knowledge of our safety reps to areas where service users would otherwise be exposed to an avoidable infection and a risk of death, then I think that would be good. And I think the inquiry could say something in that kind of territory. In addition to something like sick pay, that seems like a low-hanging fruit thing because it actually had been observed and recognised as something that could and should be done, which has been temporarily lost. But if we could bring that back, that would be good.
Thank you very much.
Thank you. Thank you, Mr. Hunter.
Thank you.
You're back after lunch, Mr. Stephen. I think that's correct, isn't it?
That's right, yes, that's right.
Yeah. I don't know if the witness will be here, but if we've finished a little bit early, if you can start at 10:02, I'm happy to do that.
All right, I'll check. Thank you.
Yeah. Thank you.
Thank you.